When payers question your ASAM levels of care, your documentation is what defends them, or what loses the claim. The ASAM criteria decide the level of care. Your records decide whether it survives review. Let us walk through the ASAM criteria levels of care and how to document to them for treatment center operators, not clinicians. We will cover what the ASAM criteria are, the 6 dimensions, levels of care, and the documentation workflow payers expect. So, what are the ASAM criteria? ASAM stands for the American Society of Addiction Medicine, which publishes the ASAM criteria and its implementation materials. ASAM describes the 4th edition as a person-centered set of guidelines for building treatment plans for addiction and co-occurring conditions. For operators, the practical issue is documentation, showing why the current service intensity fits and why the next transition is defensible. Here is where it breaks down. Intake, utilization review, concurrent review, and transitions all need enough clinical detail to justify the level of care. When that detail is thin, payers can question the level of care, the service intensity, and the continued stay. Documentation gaps turn into authorization friction, denials, and continued stay disputes you have to fight after the fact. This is where a behavioral health platform matters. A generic EHR is not built around ASAM levels of care, and the documentation payers expect. A generic EHR has no concept of outpatient, IOP, PHP, residential, or inpatient as distinct trackable levels of care. Behave Health is designed to support level of care tracking across outpatient, IOP, PHP, residential, and inpatient workflows. And it connects that documentation to utilization review, payer authorization, and revenue cycle follow-through. The 4th edition organizes assessment around 6 dimensions. Use the current names in your documentation and staff education. These 6 dimensions are the lens for every multidimensional assessment. Here are the 6 current dimension names. 1. Intoxication, withdrawal, and addiction medications. 2. Biomedical conditions. 3. Psychiatric and cognitive conditions. 4. Substance use-related risks. 5. Recovery environment interactions. 6. Person-centered considerations, covering barriers to care, preferences, and motivational needs. The continuum still spans 4 broad treatment levels, with decimals expressing finer gradations. Here is the operator shorthand. 0.5 Early intervention and prevention-oriented services. 1.0 Outpatient treatment, now including long-term remission monitoring. 2.1 is intensive outpatient. 2.5 is partial hospitalization. The 3-point levels are residential, from clinically managed low intensity up to high intensity. 3.7 is medically monitored intensive inpatient. 4.0 is medically managed intensive inpatient. So how do you document to these levels? Keep it workflow-oriented, in 5 steps. This organizes the work. It never makes the clinical placement decision itself. Step 1. Capture the current clinical facts across all 6 dimensions. Record the present state clinical picture for each of the 6 dimensions, so the assessment is genuinely multidimensional. Step 2. Document what the clinician actually reviewed. Capture what the clinician reviewed and weighed, not only what a software field happened to collect. Step 3. Document why this setting and intensity are being used. State why the current service setting, intensity, and reassessment cadence are appropriate right now. Step 4. Track reassessments and level of care changes over time. Log each reassessment and every level of care change so the clinical story stays continuous. Step 5. Connect clinical documentation to the rest of your operations. Tie the documentation into utilization review, billing, and discharge planning so nothing falls between departments. When payers ask you to justify level of care and continued stay, an ASAM-aligned packet usually needs a few things. A multidimensional clinical summary in current dimension terms, plus admission or continued stay rationale from qualified clinical staff. The current level of care, requested dates, and the review cadence. Treatment plan goals tied to documented needs and a discharge or step-down plan. Requirements vary by payer contract, state rule, and plan type, so avoid coverage absolutes. Stop letting thin documentation put your levels of care at risk. See ASAM-Aligned documentation built into your workflow. C. Level of care tracking, utilization review tasking, and payer authorization support in one platform. Book a 20-minute demo at behavehealth.com.